Now that we've gone over some therapies and drug classes used in the maintenance of COPD, my next video is going to dive into pulmonary rehab, education, and self management of COPD. Thank you. Now let's talk about pulmonary rehab and why it's such an important part of COPD management. Pulmonary rehab is a comprehensive and structured program that includes supervised exercise training, education, breathing techniques, and emotional support for COPD patients. It's recommended for patients with moderate to severe COPD, especially those experiencing persistent symptoms. And there are several major benefits. First, improved shortness of breath. So, through breathing techniques like pursed lip breathing and strengthening respiratory muscles, patients learn how to better control their breathing during activity. Second, improved exercise capacity. Regular supervised exercise helps improve endurance and muscle strength and allows patients to tolerate more physical activity with less fatigue. Another key benefit is a better quality of life. As patients gain strength and breathing control, they're able to return to more daily activities, which increases independence. Pulmonary rehab can also lead to fewer hospitalizations. Studies show that patients who complete these programs have fewer exacerbations and better symptom management overall. Patients who attend pulmonary rehab often experience improved mood. COPD can be associated with anxiety and depression, and pulmonary rehab provides emotional support and encouragement. Lastly, it can help build confidence. As patients see improvements in their breathing and physical ability, they feel more in control of their condition. So, overall, pulmonary rehabilitation is one of the most effective non pharmacology interventions for COPD, and it plays a major role in improving physical and emotional outcomes for COPD patients. When managing COPD, it's important to closely monitor for changes that may signal worsening symptoms or an exacerbation. First, patients should monitor their breathing. Any increase in shortness of breath or wheezing, difficulty performing normal activities could indicate an exacerbation. They should also watch for changes in sputum, such as increased amount, thicker consistency, or a change in color, which may suggest infection. Monitoring oxygen levels, especially for patients using pulse ox at home, is essential. A drop below their normal baseline can be concerning and could lead to hospitalization. It's also important to monitor activity tolerance. If a patient becomes more easily fatigued or dyspneic during exercise or cannot complete usual daily tasks, that also may signal a worsening exacerbation. Increased rescue inhaler use is also another key warning sign. If patients need their rescue inhaler more frequently than usual, their COPD may not be well controlled. Other important signs to monitor are symptoms of infection, swelling or heart-related symptoms, and even mental health changes such as increased anxiety, depression, or confusion. Now moving on to patient treatment during symptom worsening. Patients may need to increase their use of their rescue inhaler as directed in their action plan. Oral corticosteroids can also be prescribed to reduce airway inflammation during exacerbations. And if a bacterial infection is suspected, antibiotics may be necessary. Some patients may require supplemental oxygen, especially if their SATs decline. And it's critical that patients follow their individualized COPD action plan, which guides them on when to adjust medications and when to seek hospitalization. Which brings me to seeking emergency care if needed. Patients should be educated on this, especially for severe shortness of breath, chest pain, or confusion. And finally, long-term management should focus on preventing future exacerbations through medication adherence, vaccinations, smoking cessation, and routine follow-ups. Now let's talk about the criteria used to prescribe supplemental oxygen in patients with COPD. It's important to understand that oxygen is prescribed based on objective evidence of hypoxemia, not simply because a patient feels short of breath. Dyspnea alone is not an indication for oxygen if oxygen saturations are normal. The GOLD guidelines recommend long-term oxygen therapy for patients with chronic stable COPD who meet very specific criteria. First, oxygen is indicated for moderate to severe resting hypoxemia. This means a PaO2 of 55 or an oxygen saturation of 88% or less while breathing room air at rest. In addition to resting hypoxemia, oxygen may also be prescribed for patients who desaturate during exertion. If sats drop to 88% or less while activity is going on and improves with um, supplemental oxygen may be considered. However, this is primarily for symptom relief, as a survival benefit has not been clearly established. Oxygen may also be considered for nocturnal desaturation. This would be if their sats drop to 88% or less while the patient is sleeping. Supplemental oxygen is also given when a patient has just had an acute exacerbation. So that would be also when the sats drop below 88%, and our target saturation range for COPD patients is 88 to 92%. This is important in patients who are prone to hypercapnia to avoid worsening carbon dioxide retention.